Good morning. Thank you for the invitation here. It's a pleasure to be talking here, and it's really been a privilege for me to work on this project about which I want to share some information with you. The project has been something that I've been involved in for about 12 years now, starting right around 2004. It's work that we're doing in rural India, and I've been very lucky to get the opportunity to work on various aspects of this project. So that's what I'd like to talk about. So the broad topic is the pursuit of the United Nations Millennium Development Goals and Sustainable Development Goals. And in case you're wondering what the connection is with e-business and so on, I will make that connection as we go forward, because one of the things about this topic area that fascinated me initially is that when we think about technology and when you think about some of the work that I had done in the past and many people have done in the past, is there's a lot of business practice, organizational impacts, and so on. But this is very much focused on societal impacts and really making a difference with technology in the lives of the poorest of the poor people in the world. So that's what I'd like to discuss with you. And given the time constraints, I've cut down a couple of things, and if you want the academic articles, I'm happy to share a lot of the papers with you. What I'd like to do is to give you some of the story behind the story rather than talking about the papers, which you can read and get the information. So what I'd like to first talk about is the notion of poverty and how our view of poverty itself has changed. Talk about United Nations Millennium Development Goals. There were 8 Millennium Development Goals that were adopted by the UN back in 2000. And in 2015, they've been changed, and they're now called the Sustainable Development Goals, and there are 17 of those. And then the context of rural India. What are some of the challenges particularly faced in rural India, and what our intervention has been, and what we have studied and tried to study in this context. I'm going to skip over the academic articles because we don't really have the time to delve into those details, but I can, again, happy to share with you in more detail the papers themselves and some of the key implications. So first, the view of poverty. When we think of poverty, we've always traditionally thought about it in terms of just the idea of income or money. That view has really changed because just having access to some money or increasing the access, giving access to more money doesn't necessarily solve all the problems. So the view of poverty has changed to become much more multifaceted, as you can see here, ranging from nutrition, education, access to health care. These are the types of things that need to be addressed in order for better quality of life to emerge, which is obviously one of the main things about getting rid of poverty or overcoming poverty for the poorest, especially the poorest of the poor, is to improve their quality of life ultimately. So in many instances, what the interventions do is they simply throw money at the problem. It's the easiest way to solve a problem, or to try to solve a problem, is to throw money at the problem. Right? People give money, and then the people who receive it should somehow solve their own problems. But actually addressing infrastructure issues, access issues, healthcare access issues, and so on, providing educational access are very critical. So this view of poverty has changed to include 10 different indicators, and this comes from work that dates back about a little less than a decade at Oxford University, and this is being embraced in a lot of different settings when we think about how we want to use interventions specifically to address various aspects of what really poverty is. So like I said at the outset, the Millennium Development Goals were originally adopted by the UN at the turn of the millennium, and the idea was they have targets against each of these 8 goals that you see: ending poverty and hunger, education, etc. They had targets that needed to be achieved in various parts of the world, the less developed countries, over a 10-year period. So in 2010, perhaps not surprisingly, while some progress had been made, pretty much everywhere in the world we were very far behind where we needed to be relative to those targets. So in 2010, what was done was revised targets were set for 2015. So new targets were set for 2015. And again, in 2015, good progress had been made. And in some countries, more than others, better progress had been made. But when you look at some of the countries where they didn't make adequate progress, or some of the goals against which they didn't make adequate progress, India, China, parts of Africa, and emerged as regions where they didn't make adequate progress, particularly certain parts of these areas. And the progress was least when you considered women's issues. Various types of issues ranging from healthcare access, education, financial resources access, and so on. So progress was far less than what they had aimed to achieve. And so new targets were set for 2015, and they were also not met. As this process was happening, one of the things that was interesting is that the role of information and communication technology was seen as more and more critical to the achievement of the goals that were set. More and more critical to the achievement of the Millennium Development Goals. So largely I imagine it's preaching to the choir if we say that, well, ICT can provide informational access that can really help with the achievement of a lot of different goals, including education, healthcare, and so on. So ICTs were very crucial. So this is how I got involved in this project. I'm going to tell you more about the intervention. The idea was to try and disseminate information through technology in rural India. So that's the general idea. The Sustainable Development Goals, in 2015, when the UN reassessed where they were, in 2015 they reformulated these 8 goals, expanded them, and created 17 goals. And each of these goals has a lot more detail associated to what are the different things we want to do and what are the different things we want to achieve, and measurement and targets associated with each of these specific goals and sub-goals, and for each of the different regions. So I'll just give you a flavor for it. So this is what Sustainable Development Goal 5 would look like. Okay, so there are various different goals, and then there are specific targets. So you don't see the targets here. So achievement of particular levels of progress toward each of these goals was what was formulated in 2015. Just to give you an example, something that's particularly relevant to the work that we are doing is enhancing the use of enabling technology, information and communications technology, to promote the empowerment of women. And then associated with this would be specific targets of how we can assess the empowerment of women and what targets we're trying to achieve in various parts of the world. Okay. So this is an example of a particular goal. So that's about the role of the technology and technology being critical. The next is, why is rural India important? Because often when we hear about India, you hear about a lot of the progress that's been made, the growth in the economy, the growth in the middle class. Yet some of the challenges associated with rural India or the poorest people in India is worse than anywhere else in the world. So some of the assessments indicate that there are more people living in poverty, or they often call it abject poverty or desperate poverty, which is defined as living on less than $1.25. At the start of our study, it was living on less than $1.25 a day. Okay? There are more people living in poverty in India than in the 26 sub-Saharan African countries combined. And there are some particular states in India which are particularly underprivileged from this perspective. So we don't normally hear about this. You hear that there are some difficult conditions and so on, but actually having traveled in villages in India as we were working on this project, you just discover how deplorable some of the conditions are. And there's no running water, no access to electricity, none of the modern facilities that we might imagine. There's any access. Healthcare access is 10, 20 miles away, and it's not on motorable road, etc. So the conditions are actually quite challenging. So it's a very important context to study. There have been a lot of efforts, ICT-based efforts, to address this issue, address the issue of poverty, address the issue of various aspects of poverty in various parts of the world. And basically these things take two main approaches, two main things that they try to solve. One is access. So giving access to people to technology, that's the first issue. The second is actually fostering use of the technology that's been deployed so that positive consequences may ensue. Right? The first part, which is access, it's an easier problem to solve because you simply throw money at that problem. So if you can generate enough financial support, you can say we can make access available to millions of rural Indians, right? But then how are you going to get them to use it? I'll talk about some of the challenges that we encountered in this, because when some of the villages that we visited, many of the villages we visited, the literacy rate was near zero. And the literacy rate among women was absolute zero. Literacy, when we talk about literacy, the government of India actually defines literacy as anyone who has attended fifth grade, has had fifth grade education or greater is considered to be literate. And so when you consider that, these are people who can neither read nor write. So just giving them access to technology would solve absolutely nothing. There have been many initiatives that have been put in place by the government of India, by non-government organizations, NGOs in India, by multinational corporations which have had a significant presence since the early 90s. There's been a growth in the number of companies that have a significant presence in India, ranging from Microsoft, Cisco. All of these big corporations have very large presence in India. And so as part of their corporate social responsibility, community activities, they do reach out and try to address many of these concerns. But the easiest thing for them to do is actually to give money. They have plenty of it and they're willing to give money. But these don't usually solve any problems. I'll tell you some of the stories of what we discovered as we got into this project. In India especially, all of these companies have a lot of initiatives going on, and if you just search online, you'll see tons of these initiatives that exist, and the results are still very mixed. Most of the time, they do focus on access. So, company will adopt a village. Adopting a village means giving something to a village. They're willing to put up a building, donate some computers, etc. Then nothing may happen. It's just donating of the computers, and then they'll say immediately that they can count that as a success if you're talking about access. Those 3,000 villagers now have access to technology, right? So you can count it as a success if that's how you measure success. So that's not really the core issue. You're really trying to use this technology in some way to actually create positive consequences. Really, you're trying to use the technology in some way to create positive consequences. And as we started working on this project, what we were trying to do is to gather evidence about what are the success stories out there. Where's there evidence of success? And we really found that most of the cases there's either no usage, no data available, or the initiative has been completely abandoned within the first 3 years. Right? They put in place some initiative to make available some sort of access to technology. And then nobody in the village, for instance, knows anything about the existence of this initiative anymore. So a lot of these initiatives failed mainly because there's really no follow-through. It's just about making the access available, counting the win, and then moving on to the next village. Because there's no benefit if you're counting access for a number of people. There's no benefit to giving or trying to help the same 3,000 people. What you want to do is to help a different 3,000 people so you can get better numbers out of it. So these initiatives have largely been unsuccessful. So the first change as we went into this project that we tried to initiate is to involve more stakeholders. So typically only one company was involved in trying to make this work. So we tried to first change the nature of the intervention from being just, they would put up a building. This was the initiative in which we got involved. They would put up a building. They would have a computer or two installed. Depending on the number of people in the village, they would have 3 computers, but the computers would just gather dust, right? In some of the villages that we went, and this particular initiative was targeting 800 villages over a 6-year period. Some of the villages where they had already done this, implemented this intervention, we go in there, the computers have been removed, and this building that's been built was used for storage. Storage of different either farming equipment or produce or something like that. So it was a nice building, so it helped to protect some other assets that they had rather than being functionally used for the computer. So the first thing that we changed was to try and introduce a staffed kiosk. So what that was we worked with NGOs like the Lions Club or other organizations and recruited people who wanted to spend time in the village, typically 2 months or 3 months. They would spend 2 or 3 months in the village, and they would use the technology and try to provide information to those who might come there. imagine this would be very important because those are actually trying to get information, be it a farmer or be it someone else who is trying to get healthcare information, a woman trying to get information about healthcare during pregnancy, etc. They have no way to use the computer, right? Instead, there would be someone who would facilitate the use. This graphic actually comes from a paper in IEEE Transactions on Pervasive Computing by Parekh and Ghosh. And there they talked about the different modes of technology use in less developed countries. Actually, their example is specifically in India, in rural India. So you can see that it's a little bit different from the mode of technology use in which you and I might engage. Or we just sit in front of the computer or whatever device and we can just use it. You can see in all of these instances, there is some form of mediation of the use of the technology by someone else, some form of proxy use, which is what they call it in the umbrella term being proxy use. So there's some way in which somebody else is facilitating the use. So that's the first piece of what we did. The other thing that we learned in the early stages of the project is that just providing this internet access and then making this world of information available to the person who is sitting at the computer was actually somewhat counterproductive, because all they would do is they would get on the search engine and try to find answers to farming questions, and they've never farmed in their life, or they're trying to get answers to some healthcare question, and they've never actually been a healthcare professional. In most instances, they've never had any sort of healthcare experience. So they're simply going to look up information like you and I would and be completely overwhelmed by the amount of information that they would get, right? So we changed over time the intervention by partnering also with different specific agencies. This is an example of one such agency. This is the National Health Portal, where the information that was going to be available was much more distilled and reduced to the very essential information. So now we're actually working toward eliminating internet access entirely, because a lot of this information we can just store locally. So the role of the internet as a critical tool has changed from the way we viewed it in the beginning. The internet was going to be crucial to getting all this information, versus now we're looking at it differently. So this is also available in different local languages. You're seeing the English version here, and you can see that the information that's available is, again, very succinct. So it gives them some basic information. And the other thing that we have also moved toward is more multimedia content in the local languages. Again, for very important things related. I'm talking here about particularly about prenatal care and infant care and child care and so on. So self-care behaviors in which that the women can engage, or care behaviors that can be enacted on the infant or the child. So there's some information that's available. Similarly, we have information for lots of different potential symptoms that might exist, so that they can get some level of care through this. It's not to try and give them access to WebMD so that they can try and self-diagnose everything, but rather to point to when they need to see a healthcare professional. Okay, so when they need to see a healthcare professional. So this is the second piece. So there's a first piece, which is staffing the kiosk. The second piece is to actually control the amount of information. And then the third piece is to work with hospitals and clinics and doctors. There are lots of hospitals which want to make a difference, and a lot of doctors who want to donate their time. And trying to have actually small clinics, because the bigger hospitals are in the towns, and like I said, they're 10 to 20 kilometers away, so 10 to 20 kilometers or miles away. And it's not the same as how you and I might view the distance. We might say, oh, that's 15 minutes away. So I've traveled some of these 10 and 20 kilometers on non-motorable road, and that's usually 6, 7, 8 hours away. So it's not really the same, when we think about it. These are very remote areas. So trying to create these clinics in places where that might be closer to these villages, and have the doctors spend time there, those who really want to make a difference. So very small buildings, and then working with the pharmaceutical companies to donate medicines to the doctors who are providing care. So you can see what we did really was try to create a lot of complementary things around these technologies. And the government, of course, is also engaged in a lot of different initiatives. So one of the things that's happening in India is the there are mobile clinics. So of course, this means the doctors or the healthcare actually goes to some of these villages. So, but that happens once a month or once in every 2 months or something like that at some arbitrary frequency. And that's not going to help someone who is just sick at a particular point in time. They need to have access to healthcare. So the role of the clinic and the role of doctors and the role of medical supplies becomes important, regardless of some of these, efforts that are being taken. Okay. So what we are doing in terms of looking at this problem as well is to change the focus from trying to maximize the use of the technology. We would like to see more use of the technology, but changing the focus from trying to maximize the use of the technology and focusing on another aspect, which is the social networks. Okay, the social networks in rural India is very crucial. First, it's a very collectivist culture. Right, so people do a lot of things collectively. People do a lot of things by sharing information and so on. It's very different from a Western culture, which might be more individualistic. Very collectivist culture. Very low literacy rate, which means that again you're relying on other people for information. You're relying on your social relationships for information. And perhaps because it's a collectivist culture with a low literacy rate, this oral tradition has been the way that knowledge has been passed from generation to generation. How farmers have stayed farming or learning about the practices or anything that's been shared, stories, etc. A lot of the oral tradition is what drives much of this. This actually is something that cuts both ways, in the sense that if you can infuse something into the network, it can potentially have a positive impact because the information likely diffuse quickly. But it also has a big negative, because in these situations, in this context, the big challenge is really that they are very wedded to the traditions that they have always, and the beliefs that they've always held. So for instance, as in working in these places, they sort of see more modern medicine as evil. They would see the traditional way of there are some very graphic videos on this as well that you can find. I would see the traditional ways as the right way to do it. That's the way that God intended it, and things like that. So there are some very, very superstitious beliefs around some of the things that they do, and there's a real great aversion to changing these things. So breaking through with trying to say, okay, well, this is, what you're doing is wrong, and making them switch is not very easy. And when you're trying to do that, especially in terms of trying to help women with prenatal care or infant care, that's particularly more challenging because of the role and the oppression that they might face in the situation, and they don't really have access to resources, financial resources, etc., to be able to do anything different from what the people around them tell them to do. So it's a very, very challenging thing that we have to contend with. So our conceptual foundation is essentially looking at various types of outcomes, and I'll give you some flavor for the types of results we have. We're looking at income, how the farmers who access information through the kiosk and also through their networks, the types of benefits that they see. We're looking at entrepreneurship among women, and we're looking at infant, child, and maternal mortality. I'm going to talk a little bit more about that. And the behaviors that we are trying to change, we're trying to change technology use. When this project started 12 years ago, the main focus was let's just maximize technology use and then we'll be fine. But we've since changed that to say, well, we're not really that interested in maximizing technology use. What we're interested in is the diffusion of information. If we can get one person to use the technology, as long as we can diffuse the information, we'll be in great shape. Then self-care, just self-care, healthcare. And then medical care, seeking professional medical care, not the other things that they usually use. And then the networks. There are different types of networks that are crucial here: advice networks, friendship networks, and then hindrance networks. The hindrance networks are the things I told you about, where people actually prevent you from doing something, and that's a very powerful negative effect. So this is what our general framework is. We have several different papers related to this, and I'm happy to share with you more information through the papers. The project itself, I told you, 800 villages. We started with 10 of those villages back in 2004. And now we've just expanded to 50 villages. We have lots of new ideas about what we're going to be doing with these 50 new villages. It's one of the things that I'm starting to work on with my sabbatical this year. Okay, let me tell you a little bit about what we have been doing from a timeline perspective. We got the villages and conducted a lot of different interviews, and then we designed the survey. We're doing a social network study where we're getting information about the nature of the interconnections among the people. And obviously when we're dealing with people where the literacy rate is near zero, we're not going to send them a link and say fill out the survey. So all of our surveys are done through personal interviews. And because they're network surveys and you're asking about relationships among people, it's very sensitive information. So there's a lot of trust building that needs to happen, and there's we're not getting people in the village to do this. And so it's very effortful. We have about 20 people who are working full-time for the data collection. We do a survey every year of the people. In each of these villages, this started with the 10 villages. In each of these villages, a computer is installed and there's some training that's given. The training that's given is not a point-and-click training, but rather if you go to the kiosk, if you go to the computer center, what sort of information can you get? You can get information about farming, you can get information about healthcare, you can get information about taking care of your infant, that type of thing. And so some specific examples are given. Medical practitioners will come and talk to them and say, what sort of things they need to do and so on. So it's more about what information you can get, the information diffusion aspect, rather than using the computers per se. Then we measured use. We would just track use, both in terms of the specific sites that were visited or the specific type of information that was accessed, and also the amount of time that they would spend visiting the kiosk. And we've been tracking various different outcomes. Like I said, we're tracking economic outcomes, which is income. We have to have several different sources because most of these people actually, they are well below the poverty line, and so they don't usually have to file any taxes. So they're not really very reliable government sources, even if we could get access to them. So we have to rely on their self-reports. We have to rely on market information where they sell their produce and so on to get that information. And from a health outcomes perspective, we have to get multiple outcomes. If they're seeking medical care, we've got to get information, the data from the clinics. And then we're also collecting very difficult information directly, which is mortality. So we're collecting data about infant, child, and maternal mortality. So we get that also from the clinics or from the individuals. From the families. I'm going to skip this in the interest of time. It's just what type of data we're collecting. It mirrors what I mentioned to you. We collect social network data and individual data. We also collect various archival outcome data. So let me give you the flavor for some of the results and why as we are moving forward, we recognized and found that really, it's not about maximizing technology use, and it'll be very difficult to maximize technology use, particularly among women. So you can see this is over an 8-year time frame. The percentage of women using the kiosks is about 8% after 8 years, starting around a little less than 5%. So it's a very low base rate. So if we're saying we're going to try to get that to 100%, it may be lifetimes later. Among men, it's grown a little bit more. It started around 20%. It reached about 30%, right? So it's still not, it's not nowhere near where we would want it to be if we're trying to say everyone needs to have access. So it's really not a problem of technology use. We will never solve any of this by, technology use. You're seeing lots of zeros on the other side, but there's actually numbers 10, 20, 30, 40, 50. So you can guess, I guess. So the dotted line is the control group. I think you can see that down here. That's the control group. So I told you, there were 10 villages which we studied over this period of time. And then we have 10 adjacent villages, geographically proximal, similar villages, which were the control group, which means that they did not have access. There was no intervention in that village. I shouldn't say they did not have access, because this is just naturally occurring in the sense that we didn't prevent any spillover. So what if they went to the other village? What if they talked to people from the other village? We have no control over any of those things. In fact, if those things happened and we still observe differences, that's an even more conservative test, right? That's an even more conservative test. Even after the spillover, you can see that there is some natural growth in the income. This is the percentage of increase in income over time. These are adjusted. This would be reflective of inflation, which is fairly high in India. It's about 5-6%, and then consequently, the government has an agricultural price index, which would also be rising. So you see some amount of increase in income over that period, but you can see that increase is more substantial when the access is made available to the kiosks. Okay, mortality rates. Mortality rates are reported in terms of number of deaths for every 1,000 live births. Number of deaths for every 1,000 live births. That's how it's reported. And that's how the UN tracks it. That's how the various agencies track it. The lowest mortality rates are in Singapore. It's less than 2 for every 1,000 live births. It's less than 2 for every 1,000 live births. In rural India, in India, at the time when we started this study, it was roughly 50 to 60, depending on which part, for every 1,000 live births. 50 to 60. And now we're talking about infant mortality, which is under the age of 1, child mortality, which is ages 1 through 5, and maternal mortality. These three numbers, now you can start adding these up in a sense, right? Of course, if an infant dies, the child mortality is not relevant, but you can have infant mortality happening and maternal mortality happening. When you start adding up these numbers, they're terrifying numbers. And so when we went to some of these rural parts, the most remote parts, these numbers were even worse. So you're talking about 70 out of every 1,000 lives, 7% mortality rates, extremely unacceptable, right? So the dotted lines represent the control groups. Those are the 10 villages where there was no intervention. So there's the red line and the blue line and the green line for maternal, infant, and child. So you'll see that there has been downward trend in each of these cases. The dotted lines above, so the higher the number, obviously the worse it is. So you can see in the villages which we started studying, there were over 70 when we started. There were over 70 deaths for every 1,000 live births. So in the intervention villages over time, you start to see this reducing. And so one of the things is that the reason we see a general reduction is that there's more effort for all sorts of preventive care, and there's more access to health care, and there's more efforts by the government in general. So you can see a generally reducing trend, even in the villages that don't have the intervention. But in the villages where there is the intervention, we're seeing that the drop is more significant. And we're learning more as we go. We're discovering what are the things that make a difference. And as you saw, it was not necessarily the technology use, much as we'd like to evangelize about the technology, since the technology makes all this difference. It's really the information and how we can get the information. So that's what we're trying to rethink right now. And I'm going to tell you a little bit about some of the plans we have as we think about this. And that's where really the connection comes to e-business. There's a lot of different opportunities as researchers to think about how we can do work that's paradigm breaking. Think about how we can stop thinking about the technology design and everything in terms of the way we've thought about it for the top of the pyramid, the most affluent, the most educated, and think about how we might make this available to the bottom of the pyramid. So completely different way of thinking about this problem. So let me talk about some of the key implications that we have learned. And I'm not talking about it necessarily from the perspective of research per se, but it does have some research implications. The complementary investments are key. So just the technology or technology access alone was not sufficient, because this intervention efforts, the access, was going on for years before we got involved in the project and tried to study some of these things and change the nature of how this project is deployed. So complementary investments are key. The former president who passed away recently, he indicated that as much, that India needs to make more infrastructure investments such that they're complementary to some of the things that we're doing well already. So in our case, making available the access to someone to help the information be available, the staffed kiosk, the access to the clinic, providing this type of additional access made a big difference. The second thing is designing for the bottom of the pyramid. Designing for the bottom of the pyramid. And right now we're just thinking about it in some simple terms, like saying information overload, which you and I would find problematic as well. But we may be better at sifting through this information. But just think about, whenever I've felt like I wanted to go to WebMD and typed in some symptoms, I always feel like, I've got 24 hours left. Right? All of those symptoms will ultimately lead to like something extremely, going to be fatal in just a matter of minutes. So now you switch that, and here's someone who's coming there and has no idea and is trying to get help from another person who has no idea about this. So this information overload problem really is very magnified. But that aside, when we're thinking about these technologies, what we're doing is really saying, let me take this and put this in a place where these people are never trained to use this technology. Right? So that means we cannot, there are over 500,000 villages in India alone. Right? We cannot staff kiosks in every village. It's not going to be possible. All we're doing right now, all we feel like we've done right now is found some sort of proof of concept to the idea that making some level of information available with some complementary investments can make a difference. So we have to solve this problem some other way. And I think that there's a fantastic opportunity to think about it in terms of designing for the bottom of the pyramid. So the pyramid idea is that the top of the pyramid, the people are the most affluent, the most educated, and so on. And this is our paradigm. We know how to do this. If we put a phone in front of us, we know to swipe. Or if it doesn't swipe up, we'll swipe sideways. We'll figure that out. But you put a phone in front of them, they wouldn't know what to do. Right? So the paradigm is very different. So designing for the bottom of the pyramid is a fantastic opportunity, both from the perspective of practice, but also from the perspective of scientific progress. Right? We've never really thought about these people as being particularly important for what we do. And technology use is good, but really networks are how we are going to get this problem solved. We're going to have to think about how can we mitigate the negative effects of the hindrance networks. How can we overcome some of these socio-cultural barriers that exist by leveraging the networks, by thinking about confederates, by thinking about women who might play powerful roles. So one of the papers on which we're working right now is looking at how when there are some entrepreneurial women that are created essentially in these villages, how they can then get a presence in the local government, and how they can then draw attention to women's issues and healthcare and so on. So changing the very nature of how to think about the problem, rather than just saying technology is all that's needed, is what we would think. Yeah, so the other thing, as I mentioned, there are over 500,000 villages. We're really not going to solve this problem through just providing technology access and people access, like you're not going to get staffed kiosks everywhere. We really have to think about the design. There are a lot of Indian companies that are working on it, also in terms of making more rugged technology available, cheaper ones, the technologies that will be low power consumption. So there's a lot of different other things, like you and I can go and charge our phones every night and so on. So there are very unique challenges that are faced in these contexts. And one of the things I said we've discovered is that I don't think the internet is as crucial as we think it is for the types of things that we're trying to address. A lot of the information is static, doesn't change that frequently, and can be updated on periodic basis rather than constant need for internet access, which means that opens up a whole different avenue of how can we get that information to them. And again, televisions and radios have been there, but they don't solve the problem either. So we did have a great recognition for the project back in 2010 when it was recognized by the UN as one of 12 projects where we were actually making a difference in the lives of people. I got to present this at the UN in 2010. 2010 was a very important year in the life of the UN because in 2010 they created a new division of the UN in 2011 they created a new division of the UN called UN Women. Which brought under one umbrella all of the programs and all of the units that were actually dealing with women's issues. because they found there's a lot of redundant effort and a lot of, left hand doesn't know what the right hand's doing type of thing that was going on in the UN. But that division reported directly to the Secretary General of the UN, but that was a very important step in terms of bringing together the focus on women's issues. And so we got to present and learn from some other projects as well, which has fueled some of the ideas. So what we're now thinking about doing is really, and I think that this is, I would encourage people who are interested in, thinking about e-business and technology design, etc., e-services, to think about the services and the technologies not just for the top of the pyramid like we always have been, but think about how we might design it for the bottom of the pyramid. So focusing on the technology design, whether it's technology, the touch screen, the websites, the content, the portals, how the language that we use, all of these things are really, we should just throw everything we know out and start thinking about how might we do this. Because every time what we do is we say, oh, let's see, how can we modify this to fit the population that we want to serve. So I think that's not the right, I don't have any answers. That's what I hope to, work on this year. But I think that it would be something that would be a very, very worthy research effort. Imagine answering some paradigm-breaking questions like that. This is what Thomas Kuhn would say we need to do. So we keep on going and doing normal science. We're just doing things the same way. And then suddenly the things that we're doing, anomalies occur, no longer work. We put these technologies in place and they helped us, you and I, be productive. But it doesn't change the lives of these other people because they don't know how to use them. So then what needs to happen is a scientific revolution needs to happen, right? So we need to break with the paradigms that we have and do something different. Developing and testing scalable solutions. So like I said, we've got a proof of concept of some things working. An intervention with complementary investments seem to be working. But how do we scale this? How do we scale this? And how do we then think about what happens cross-culturally? This is just India and with its unique idiosyncrasies. What happens if we go to China? What happens if we go to different parts of Africa? Again, we might be starting over. And one of the things that I'm going to talk about later in the workshop is this role of the context and why context is so important for scientific progress. And finally, the development and testing of content, both for our websites and mobile sites. We need to think about that as well. One of the things we learned, like I said, is we really need to pare the information down, not increase the information, right? So we need to think about how might we design the content? How might we design the content? Simple answers are like what we've already done. More multimedia content, right? More content that's video and audio based rather than having to be text that's read, right? That's one simple thing that we've thought. But there must be other things. There might be other things. There are other ways to do this, because we're talking about some very difficult issues as well. We're talking about pregnancy, infant care, and so on. So we're talking about some challenging issues. How do we communicate this information in a manner that's effective? And this has the attention, this has the interest of the medical community as well. And here's our opportunity as people working on technology and technology design to provide them the answers. So these are some future directions that I think we're interested in, but others who are like-minded can also embrace. So that's what I had. I don't know how we're doing on time, but any questions, comments? Thank you.